Okay, so we are talking about shoulder the next few weeks. So we'll open up the Clinical Pattern Recognition Shoulder Pain app, and we are going to look at shoulder pain patterns, right? So you have some pain patterns that go into the arm. Some are in the anterior and posterior shoulder, deep inside. Some are at the tip of the shoulder. You have here tip of the shoulder that radiates into the upper arm, and then you have this global arm pain, global shoulder pain here at the bottom. So we'll take that and let's look at the possibilities, the possible hypotheses, and you see, adhesive capsulitis, possibility. And of course, labral tears, slap lesions can also present in this way. And burning, horrible pain in the arm could certainly be related to cervical radiculopathy or thoracic outlet syndrome, right? So you have a few of these possibilities. So pain patterns in and of themselves don't really predict exactly what the pathological structure is, but it does give you a glimpse, right? It starts your clinical reasoning process, your pattern recognition. So we're going to talk about adhesive capsulitis today. And when you look at the prevalence, again, you'll see that 2 to 5.3% of the general public, right? And there's an association with diabetes and thyroid disease. You can always watch the different phases played out here. Remember, in our talk this week, you can go back and watch at the Facebook Live. The talk this week talked about 4 phases, right? An early phase, you can see here as we observe the video. The early phase has a person who's complaining of a lot of shoulder pain that's worsening, and they're having difficulty sleeping at night. They may have difficulty with range of motion. Typically, active range is more limited than passive range. These patients are typically pain limited, not so much mobility limited. As you move into the second stage, the freezing phase, the patient's still having a significant synovitis, having a lot of pain still, and now the range of motion is becoming more equally limited, especially external rotation. In the frozen phase, they're having problems with their hand behind their back. They're having problems lifting their arm. The frozen phase is really, you should notice, a very strong capsular pattern, loss of external rotation, right? So from here, you can move into the thawing phase. And remember, these phases can last almost a couple of years. So you have to help the patient be prepared for the long haul and not be afraid, and work with a therapist to be able to figure out how to manage this problem. So you can watch this clinical findings video to help get that clinical picture. And just remember that this frozen shoulder patient doesn't just mean you go in and start mashing on the shoulder. So when you look at the physical exam, you're going to look at the key findings, and because this patient's disability is primarily related to mobility problems, you're looking for significant loss of range of motion, of flexion, and external rotation, right? And when you go in to do your assessment, your standard physiologic active range of motion, and you can see all of those videos there. Your accessory mobility is the primary examination for mobility deficits. Would I test strength? Yeah, I think testing strength is relevant because you're trying to rule out, is this an impingement, a rotator cuff problem? So here, as we look at primarily the movement faults, you can see that there's a common early shrug, right? A shrug with the shoulder. You can see patients using their upper traps a lot and trying to elevate the arm. And the associated impairments may be a thoracic kyphosis, continuing to add to the problem of shoulder elevation. Of course, this is associated impairment, it's not the primary impairment. If you're trying to rule things out, the guidelines will say, hey, age under 40, probably not frozen shoulder. Okay, look at full pain-free motion. If they have pain-free motion, then we are not as worried about it being a frozen shoulder problem. When you look at your pain pressure threshold, you can also try to determine, is there a marked increase or decrease actually in pain pressure threshold. Okay, we want to clear the cervical spine, clear the thoracic spine, rule out upper limb neurodynamic findings or contributions. You can see that we're doing this test arm by the side because the patients obviously have difficulty moving their arms into abduction or flexion. And then the guidelines also says, so test the rotator cuff, rule out impingement or rotator cuff pathology. So you can see that there. And then palpate nerves. Okay? So those are the common nerve entrapment sites. When we come to the interventions, we want to take a look at the manual therapy interventions. Now, remember, if they're high irritability, just like the guidelines defines, then we want to do things that are typically short of pain, gentle oscillations, deep pressure to the muscles. As the patient moves into more of the frozen phase, then we start using more moderate level forces of mobilizations. You can see posterior and inferior glides. And we can also begin to progress from low to high repetitions of passive range motion and slowly go into the end range stretches. So that's the point of thinking about frozen shoulder as being a multi-phase, a multifaceted pathology that has different phases that we need to manage differently. So when you look at therapeutic exercises, if you're trying to restore mobility, hey, well, if they're highly irritable, then do some really gentle stuff, some distraction, pendulums, gentle closed chain, shoulder range of motion. If they're moderately irritable, hey, I can start moving into some resistance. So your cane exercises, your pulleys. And if you're low irritability, you can now go into the deeper stretches and try to restore range of motion. Okay, so the guidelines also talks about when the patient has their range of motion restored, now we need to reintegrate that range of motion into function. So using overhead reaching education, proper hand behind back education, all of this becomes the standard return to function type of training. Remember, there's always patient education, so there's moderate evidence that education is very important. Help patients realize what's going on, how long it will take, help them to understand that there are phases, what we're going to do in physical therapy, and how they can help themselves. Okay, so that's it. Hope that's useful for you. Don't forget that each of these different components, like key findings, they all have little clinical reasoning videos that you can watch. The interventions has little clinical reasoning videos that you can watch. All right, this is Dr. Wong signing off. Looking forward to playing out the next pattern with you next week.